So today's case is a 74-year-old gentleman who presented about a month ago to our clinic with disabling left hip pain, and we evaluated him in the clinic. He had a pretty significant flexion contracture, a limb length discrepancy, which we thought clinically was about a centimeter or so. On exam, obviously, he had a very restricted range of motion, and we obtained these radiographs, which you can see he's got fairly significant osteoarthritis involving his left hip. This is our preoperative plan. We draw the inner teardrop line. We actually start with the unaffected right side. We look at where the center of rotation is. We measure that lesser troch center of rotation measurement on the unaffected side. We then go to the affected side. We take our two-dimensional templates and put this in, and we've determined that this is going to be about a 54 or 56 millimeter cup. We've noticed that we've raised the center of rotation about 4 or 5 millimeters, which is extremely common when you've got a little superlateral osteoarthritis right here. So we're going to make that up by cutting our neck on the femoral side and really adjusting it on the femoral side. So we've determined that our final lesser troch center of rotation distance here is going to be about 47. The stem size is a blade type stem with a porous cinder technology. It's a size number 4 with an extended offset. And because we'll be in the range of a 56 millimeter cup, this will accommodate a 36 millimeter, and I'm going to use a Bilox Delta ceramic head. So this was our two-dimensional planning. So we actually take that information and we actually put it on this ruler. It wasn't until we recently got into the three-dimensional planning, and we're going to go ahead and take a look at this now. So as part of the protocol, the patients get a preoperative CT scan. And this is what the image looks like right here, and this is the preoperative screen that we'll see. On this screen, according to the CT scan, we'll notice that the hip is about 8 millimeters shorter, and again, on the two-dimensional plan, we thought it was about 12 to 14 millimeters, and that there was, in fact, slight increase in offset, probably due to the lateral subluxation right here. So using this information, the next screen that we see will pull up, and this is sort of our default cup position right here. This is the cup. The size of this cup is 56 millimeters, and we'll go over that in a second. The default inclination is 40 degrees, and the version is 20. But obviously, you have the ability intraoperatively to adjust this as it pertains to what we do on the femoral side, and we'll come back to that in a second. And notice, if you will, by the way, that when you put in the new cup in this position, we've raised the center of rotation and we've medialized the center of rotation. This is a very predictable phenomena that you see. So again, you're going up a little bit and in a little bit when you put in a cementless socket. These are some of the transverse images, and Natasha's going to actually scroll through this from a sizing standpoint. Obviously, we don't want to blow out either anteriorly or posteriorly, so we're scrolling for that. And then if we go to the sagittal images at this point, what we can see is, again, we're looking for coverage front to back as we go scroll through. Okay, so we're pretty happy with this. This looks like a pretty good size of 56. We certainly could modify it up or down. Go to 30 degrees and just, you can see what'll happen as we change that plan, and you can see that we've opened it up significantly more anteriorly. Okay, so we can change the version, we can change the inclination. If you want to gain a little bit more interface and interaction between the cup and the host bone, you want to put it a little bit more abducted, certainly have the ability to do that. The other thing that you have is that you have the ability to move it three-dimensionally. I think very often we're thinking in terms of the coronal alignment, abduction, as well as looking at version, but the other thing is actually translating that cup anteriorly and posteriorly. So all, again, 6 degrees of freedom as it looks in cup position. We go to the femur at this point. We're going to get some information. This is native femoral version. So this gentleman has measured and calculated, because we do get some cuts through the knee, through the epicondyles, and the native version here is about 11. And this is going to be important. I think even with a blade stem, you have the ability to rotate that stem a bit. It can range anywhere from 5 degrees to 20 degrees, but it depends. In this particular case, we've got 11 degrees of femoral version, so I'm happy with that. It gives me enough latitude that I'll be able to adjust a little bit After we get the femoral broach in, we're going to determine what the intraoperative broach version is, and we're going to then come back to our equation with that concept of combined version. So when we put all the parts together, this is what, again, our digital representation of what our reduced hip is going to look like. And if we follow the plan, you'll notice compared to the opposite hip, we've actually restored limb lengths. And for the most part, we've increased offset by 1 millimeter, but I think that's certainly within the ballpark. And this is the projected radiographic appearance of what our recovery room film is going to look like. And right now we're working on, quite frankly, going from this slide to simply just going right to the recovery room and not having to do the operation. But unfortunately, we haven't figured that part out. So we still have to actually slice the patient open and do all this other stuff.